Welcome. Hello, everybody, and welcome to the I-STARR webinar series. I-STARR stands for Infrastructure for Studying Treatment and Addiction Recovery Residences. And the I-STARR project aims to develop infrastructure to advance science on recovery housing, particularly recovery housing for persons treated with medications for opioid. Today, we'll be hearing from Liz Mahoney, and the title of her presentation is Taking a Closer Look at Relapse. Now, if you've been to one of our webinars before, remember that the I-STARR project is supported by a grant from the National Institute on Drug Abuse, and it's part of the larger NIH Helping to End Addiction Long-Term or HEAL initiative. It is also one of several projects that comprise the Consortium on Addiction Recovery Science, or the CORES network. So just some quick housekeeping items about the format of this webinar. All audience members are currently muted, and we encourage all attendees to use the Zoom chat function to introduce themselves, connect with fellow audience members, and ask questions for our presenter. We do have an I-STARR project staff member monitoring the chat, and we'll unmute audience members after we hear from our presenter, so that attendees can raise their virtual hands and participate in the discussion at that point. Also, as many of you know, this webinar and each webinar in this series is being recorded so that those individuals who are unable to attend today will be able to return to learn from it. And finally, a reminder that closed captioning of this webinar is available within Zoom, and you can find it using the functions at the bottom of your screen. Next slide, please. Let me introduce myself. So I am Carmen Masson. I'm a faculty member at the University of California, San Francisco, Department of Psychiatry and Behavioral Sciences. And the I-STARR project is led by Drs. Amy Miracle at the Public Health Institute and me. And the team also includes co-investigators Sarah Zemore and Lenny Jason, biostatisticians Mina Subraman and Libo Lee, and communications specialist Diane Schmidt, and the team's project coordinator, Quinoja Capitini. Next slide, please. And our I-STARR project activities are guided by an amazing 17-member advisory board comprised of a diverse group of leaders from across the country. Our advisory board members represent recovery and recovery housing leaders, treatment providers and payers, national policy advocates, and researchers and educators. Next slide, please. So let me tell you a little bit about our presenter, Liz Mahoney. She's a project manager at the Behavioral Health and Recovery Studies Group at the Public Health Institute. She specializes in recovery housing and substance use policy. She currently serves as project manager for the NIAAA funded study Peer Helping, Retention, and Relapse in Sober Living Houses, examining pathways to recovery among Los Angeles area sober living housing residents. She also assists Dr. Subraman with analyses for an NIAAA funded project examining how blood alcohol content limit laws affect alcohol consumption and mortality nationwide, including Utah's recent implementation of a 0.05 blood alcohol concentration limit. With over 15 years of addiction research experience, Ms. Mahoney has managed multiple federally funded studies, including the evidence-based Sober Living Houses multi-level analysis and HIV risk reduction projects. She previously spent 6 years at the University of Pennsylvania Center for Studies of Addiction, managing clinical trials evaluating innovative addiction treatment approaches. Ms. Mahoney specializes in policy-relevant research using causal methods and has led analyses and co-authored manuscripts or peer-reviewed publications on recovery outcomes, relapse patterns, and substance use policy. So without further delay, let's turn the presentation over to Liz Mahoney to get things started on the topic of relapse and factors associated with it in sober living spaces. Thank you.
Okay, great. Thank you so much, Carmen. Hi, everyone. Thanks for joining today's I-STARR webinar, and thanks for the I-STARR team for inviting me to present. So I'm excited to share some findings from our study examining the question whether the lapses and relapses represent distinct phenomenon among sober living house residents. And if so, whether they have distinct risk and protective factors. So we are in the process of getting these results published, so we'd love your feedback at the end. We'll have a good discussion. So next slide, please. So before we dive in, I want to acknowledge the incredible study team that worked on this. So the work was led by Dr. Doug Polson on top left. He was the PI on this grant. Doctors Miracle, Zimor, and Zubaraman brought their extensive recovery expertise to assist with this analysis. And our dedicated field team, Daniel Mendieta and Vicky Paulus, were instrumental in the data collection, and this really was a collaborative effort. Next slide. So here's our roadmap for today. So we'll start with what anyone that works in recovery housing knows well. So there's zero tolerance policies for any use exist for good reason, but there's also that there are differences between someone who's given up and someone who's slipped and desperately wants to stay on track. So we'll talk about what the findings on that are. So we'll go through our methods, including how we define lapse versus relapse, and then the type of analysis that we use, the competing risks analysis. We'll spend most of our time on those results, looking at who experienced what outcomes and what factors predicted them. And finally, we'll discuss implications for practice and important limitations you should keep in mind when interpreting these findings, and have some time for discussion at the end. Okay, next slide. All right, so here it is, the core question, talking about relapse and what does that mean for recovery housing. So our prior studies have found that about 40% of the residents report substance use within the first 6 months after entering the house. And research has shown that staying in the house has better outcomes. You can see why staying in the house versus leaving is an important thing to study. So most sober living houses operate with zero tolerance policies. So any use typically results in the same consequence of eviction, but it creates a dilemma for those running the houses. On the one hand, you want to protect the recovery environment. The other, residents depend on that safety and stability. And it's one of the defining characteristics of recovery housing. But on the other hand, the moment right after someone uses might be precisely when that connection to recovery housing matters most. So here's the key question. So are those all uses episodes equivalent? And and do those isolated lapses differ from sustained relapse? Next slide. So the theoretical groundwork for this is from relapse prevention models. So this distinguishes between a lapse, or some might call a slip, and a full relapse. And they define that as a return to problematic use patterns. And these aren't just different quantities of use, they represent distinct psychological and behavioral processes here. And then a big part of this is the absence violation effect. So the psychological spiral where one slip might become a full relapse, just because of the shame and the kind of all or nothing thinking that might follow it. So I already broke my streak, so I may as well keep going. And this can get more complicated when you bring in a layer of impaired control, that one of the features of substance use disorders. So once the use begins, the brain's reward and craving circuitry can override any ability to stop. So, so we're wanting to look at, between these, this idea of the absence violation effect and how this can then end up being a relapse. And so for the houses that have the zero tolerance policies, that whole all or nothing framework can sometimes trigger that effect. So this policy can sometimes become part of that. And so looking at how does that end up playing out? Okay, so next slide. So here's something interesting. So looking into this, different definitions out there, the DSM-5 doesn't define it, but does use it. There's widespread use of the word relapse, but there's, and all different definitions vary. In there, there's two mentions as far as brain changes that may explain repeated relapses in substance use disorder. And then the AUD course involves periods of remission and relapse. So this is, one of the features for some people. So this ends up being something that people use without really much standardized criteria. Next slide, please. And so it also ends up kind of playing out with the lack of consensus in the field. You can see this in there's that conceptual distinction. So some people it's an outcome, some people it's a process. Is the difference between the two. And then you also have these empirical definitions. So there's one study by Maisto, I hope I'm saying that right, but they looked at most of the time, most studies define any drinking as relapse, whereas like there are other ones that look at it as the NIAAA or FDA definition of 4 or 5+ drinks for men and women. But crucially, what they found is that once you get into heavy drinking, there wasn't too much difference as far as predicting outcomes. This is just looking at how you have all these different definitions and how that can lead to differences within the field. So next slide. So, so for this, this brings us to the LA County. They recently had a recovery housing program that explicitly states that relapse or lapse is not an automatic grounds for eviction for those that are participating in this program. So this one, they talk about recommending that maybe for those who relapse, transitioning them to a higher level of care. For those who lapse, maybe moving them to a different house. But both, they really emphasize maintaining that access to recovery housing rather than facing eviction. So it starts to give into that question of like how evidence-based is this policy? Do these trajectories end up differing? And then we also have Dr. Marigle's work on how the benefits of having a house that's part of a treatment continuum can accommodate people based on their need of where they're at in their recovery. So the houses that did have an affiliation with a treatment program, either formal or informal, had better outcomes. So kind of the thinking is they're then able to keep them better engaged and kind of move them on that continuum. Next slide, please. So this study asks sort of this is the question. The summary is do lapses and relapses have distinct risk and protective factors among the residents? So if yes, this could support differentiated response policies. So the image here shows how the house manager and the little rock on the bottom is kind of trying to balance the residents. You might have the person who uses on the left and trying to balance also the needs of the rest of the people in the house and maintaining that on the right side. Next slide. All right, so let's get into study design and the methods. So this is a secondary analysis of 2 different longitudinal studies of sober living house residents in Los Angeles County. Both studies followed residents for 6 months after they entered the house. We're going to look at 555 residents who completed a 6-month interview, even if they left the house. But those who didn't complete a follow-up interview were not included since we don't know their outcomes. So we lost, there could be a systematic difference between those that we lost. They may have relapsed, they may have moved away, been incarcerated. So we'll discuss that in the limitations later. And we ended up pulling these because they had very similar methods, similar measures, same geographic area. Combining them gave us a larger sample with more statistical power to detect any of the differences. So it gives us a little bit more to work with here. All right, next slide. So this is just a quick summary of the one study. It was a sober living house neighborhood study that looked at the neighborhoods where the sober living houses were located to see how those impacted incomes. And both studies did recruitment in similar ways. First, it was 2 phases. First, we would recruit the house to make sure we had the house's permission to be there. And then we would recruit the residents within the house. So for this one, there were 557 participants who completed a baseline. Next slide. And the next study was similar, recruitment setup, and this one looked at how helping behaviors and the house's social environment impacted outcomes. The inclusion criteria were similar to the prior study of being, 18 or over, moved in within the last 30 days, provide informed consent, stay in touch. But this one had the difference that they had to have an alcohol use disorder in the prior year. Next slide. So how do we define our outcomes? So yeah, for abstinence is no substance use within the 6 months. And then for lapse was defined as any substance use that didn't progress to what we're calling relapse. And relapse was substance use that averaged 3 times or more per week once use was initiated. Okay, so now why 3 times per week? First, as we discussed, there's no real consensus on that quantity-based definitions. And second, the feeling that the frequency captures the patterns element of better than the quantity in an abstinence-focused setting. And that 3 or more days per week captures an established pattern of ongoing substance use, so it distinguishes it from that sporadic lapse or what we want to define as the lapse. And we also base this on the Addiction Severity Index's definition of problematic use. The ASI is a widely used assessment in the field, and so we like that they had kind of identified this as problematic to really differentiate that out. Next slide, please. So that is one thing to keep in mind when you're going through this. How would you operationalize definition relapse? We're planning to run a sensitivity analysis to see how the results differ with different definitions of relapse. So keep that in mind, and we want to discuss that at the end and hear from you. We don't have this data, but if we had asked the participant whether or not they thought they had relapsed, what if their goal also wasn't abstinence? Part of the power, I think, in recovery housing is that they have this shared goal of abstinence, but we definitely come across people that that's not their personal goal. But they like being in that abstinence-based environment. So we didn't collect that data either, but and nor do we on how long they have been absent, but I think that those are also really interesting and helpful criteria that could be great for future analysis. Next slide, please. Okay, so who ended up in the analysis? So we had 762 total in both studies, and then we selected those who had completed the 6-month follow-up so we could know those outcomes. And so we ended up with the 555 residents. So we had about an 84.5% follow-up rate, which is pretty good for this type of research, but that does mean we have missing data on about 15% on the sample. Next slide. So now we're going to go through next batch of slides. These go through different bar graphs of some of the characteristics of this population of the 555, broken down by their outcome, and then the overall will be that purple one. I'm going to go through these very quickly, and then I'll just summarize the key observations at the end of looking at these. A little bit of a spoilers. Most of these are what we found significant for either lapse or relapse, but we'll get into that later. But here you can see that gender, about 2/3 are male, which is pretty typical for our sober living house populations. Next slide. About half had post-secondary education. Next slide. This one is employment severity issues on the ASI, so higher score means more issues. Next slide. This is for before coming into the house. About a third had been homeless or unstable housing before they moved in. Next slide. We also asked about their substance of choice, and then we have that most common pattern here is going to be that we had the multiple substances, and then we have alcohol only was about 27%, which might be from that one study having an emphasis on alcohol use disorders. Next slide. This one shows about a 2/3 had a sponsor at baseline. Next slide. And prior abstinence has been a big predictor from other studies that we've done, and some houses require it. So here you see about 59% were abstinence for the 30 days before coming in. So this one it was significant for just a simple Pearson test for the outcome differences, but it wasn't in our later models. Next slide. This is the treatment history, so you could see that big jump for those who relapsed. Next slide. We also asked about whether or not they had a plan for how long they planned to stay in the house. Next slide. And this looks at how long they ended up actually staying in months overall. So the average person stayed about 4 months. Next slide. This one also looks at fees. So the average monthly fees were just under $1,000. And so we wanted to include that. Next slide. So here jumps out as far as like the different when we compared the incomes across just the groups for that. The relapse group was more likely to be male, so 77% versus 64% overall. And they were more likely to have been unhoused before entering the sober living house, so 45% versus 31%. Then also the relapse group had nearly 2.5 times more prior alcohol treatments, an average of 9.6 previous treatments compared to just 4 in the absence group. And they also stayed for a shorter, an average about 2.8 months compared to 4.5 months for the absent group. And they paid lower fees, so 716 compared to 1,000. So once again, correlation isn't causation, as we say a lot. We don't know if the low fees cause the relapse, you say, or if people are just struggling, end up in the lower fee houses. But there might be something a little more, and they might suggest there's something a little bit more going on here that would require further study. Next slide. So this is just to present the approach that we did. It was competing risk analysis or fine gray analysis. And so in traditional survivor analysis, you typically would model one outcome, so time to any substance use. So everyone who uses would get lumped together. But that can mask any sort of differences between these groups. So competing risks lets us treat the lapse and relapse as distinct, mutually exclusive groups that don't compete with each other. So you can't be in both the lapse and the relapse group. You can only have one outcome during this. So this allows us to separate out those different factors, how they predict the different outcomes, and be able to look more closely at that. And as we go through results, once again, this is secondary analysis, this is observational, and these are all meant for kind of hypothesis generating. This isn't definitive proof here. This is just meant to start looking at this because I think it's interesting. Next slide. All right, so let's get into what we found. All right, so the big picture, 61.6% were abstinent, 24.3% met our definition of lapse, the group that used but didn't progress to relapse, and the 14% relapse. So about 6 in 10 stayed completely abstinent, 1 in 4 used at least once, and about 1 in 7 returned to using 3 or more times a week. And so I think the interesting thing here is that those that lapse were more common than those that are in the relapse group. So this shows how residents who may have used didn't really spiral into that regular use. So this is a good distinction to pay attention to. Next slide. All right, so this is just talking about why this different approach would have been is a little bit different. So this is what if we had done the traditional analytical approach for that survival. This one just is time to any substance use. So you see a steady decline in abstinence over the 6 months with that steepest drop kind of in those first 90 days. And about 75% are still absent by then. And then by 6 months, about 60% are still absent. So this gives you an overall picture of what happens when a resident enters the house, but it doesn't tell us about the difference between that lapse and relapse. So anyone who uses is going to get lumped into that not abstinent category. Next slide. So here's a similar figure, but this one separates out the timing for lapse and relapse. So the absent group is no longer depicted here. So this allows us to see how the timing differs for these two events. So you can see how those who relapse initiated that use much earlier, so at a median of 67 days, and then those who lapsed had a median at around 100 days. So what this as far as thinking about what this might mean, people who relapse are going to start using sooner. So the first 30 days don't really differ too much there. You can see them kind of following along, and then you see that split apart, and you see a big separation in that between that 30 and 120 days, especially around that 90-day mark. And then you see the risk become similar as you get later on. So this kind of highlights how they have that different trajectory. Okay, next slide. So the next part is we wanted to look at what were the different factors that predict the different trajectories. So we looked at 42 different variables. I will not go over each one here. I will just we're going to go through these quickly, and then I will we'll present what is significant, and we can talk about how it's measured if people are curious about that. But just we looked at those based on prior research, what other people have found, and then we selected 13 variables. We did univariate analysis, so if they were significant below 0.05, they will be included in our multivariate models. And so you can see these are some of the demographics. Next slide. These are more of our demographics. So we have, stuff around employment and legal. Next slide. And then you get into some of those individual behavioral and recovery characteristics. Just want to note one thing here. We did not use the same measure of psychological distress across the two studies. So that one had been pretty significant in prior Oxford House research. So that one is one thing that it did not come up significant later, but it could have been a measurement. And then next slide, please. And then just more characteristics of their past, so getting a sense of their history, treatment history. Next slide. And then also looking at some of the characteristics that are from the resident's perspective, so their planned length of stay, how long they actually ended up staying. And then also they rated the social environment of the house. Next slide. And then also just getting some of those house characteristics from the house manager to include that also to see if that ends up having a difference. Next slide. Okay, so this is going to get into another, just to show that quick traditional approach, just to see what if we had done it that way. Any substance use, everyone, the relapse and lapse get lumped together, what would we have found? So this one is if we wanted to look at any new resident, what's the risk for that? So it's the male gender, more prior treatment, having a sponsor reduces the risk, longer stay reduces the risk, and higher fees reduce the risk. But then you can notice that doesn't really tell us the difference between lapse and relapse and the different mechanisms there. So that's why we go into the fine gray model. Next slide. So here also the significant findings are also bolded here, and this one or not for this one, but this is the overall what we're going to be looking at for the fine gray model for the lapse and the relapse. And I'm going to go through. I'm going to focus on each different one for what's significant. Next slide. So here what is bolded is the significant findings. So this is the lapse model. So this focuses on that outcome. And so the different factors here, I won't read out the results, but just know that those SHRs, they're going to indicate the direction and the relative magnitude of the association. So if it's greater than 1, it indicates an increased hazard, so it's a risk factor. If it's less than 1, it indicates a decreased hazard, so protective factor there. So so the wider confidence intervals will indicate a greater uncertainty. So just keep that in mind. And then go to the next table, please. And this one is the one for the relapse one. So you can see just as the amount that's bolded that we had more findings for the relapse. So we'll get more into that now. Next slide, please. So here, let's look at for the factors that specifically predicted lapse. So the post-secondary education increased that lapse hazard by 62%. And then we also have the not having a length of stay plan reduce the lapse hazard by 40%. So maybe a little counterintuitive, but maybe without the fixed timelines, they feel less pressure, or maybe they're more flexible, or maybe they had been, if they have a plan, it's because they're part of a program with a fixed amount of funding. So they ended up having to leave earlier. But once again, that length of stay, as we found before, was predictive. Each additional month reduced lapse hazard by 16%. Next slide. And now let's look at relapse. So here's a little different. So employment problems more than tripled the relapse hazard. And then you have each additional lifetime alcohol treatment, lap, increase relapse hazard by 2% for each treatment. And then for protective, the female gender reduced it by 63%. Older age was a little bit more protective, so each year reduced relapse hazard by 2%. Higher monthly fees once again came up. Having a sponsor decreased the relapse hazard by 56%, and longer stay reduced relapse hazard by 23% per month. Next slide. So here's our main finding. We had the distinct profiles, different factors mattered for each outcome, so that goes along with our hypothesis that they're distinct. Next slide, please. So one thing that was interesting was this sponsorship paradoxical finding. So this one, we found that having a sponsor had different effects, had opposite effects on our outcomes. So it marginally increased, it was just trending, marginally increased the lapse hazard, but it strongly protected against relapse. So, and so kind of the hypothesis around this that could be interesting for future studies. So maybe the sponsors are there for secondary prevention. So the idea that you have that absence violation effect if someone uses, they're able to kind of stop that. So they're able to kind of, someone might use, but by having that sponsor, they then have that protective effect from not progressing to that other group. So I don't know, something that was interesting. Next slide. So another key finding was the length of stay was universally protective. So that one was strong. So each additional month reduced lapse hazard by 16% and relapse by 23%. But the one with this is caution. We can't determine the causality, so we don't know how long staying longer protects against substance use um, or if those who avoid substance use stay longer. So that's something to consider. Next slide. So we also looked at these different risk profiles. So we have the different groups. So we have a low risk profile for people who are female, low employment problems, has a sponsor, mean length of stay compared to a typical profile. For someone with male, mean employment problems, has a sponsor, and the average length of stay compared to a high risk person who is male, high employment problems, no sponsor, and a short length of stay. And you can see comparing between that relapse risk for the low risk, 1.7% to 34%, that's a 20-fold difference. So that's pretty big between those. Next slide, please. So we also wanted to look at how the relapse risk changes over time. Next slide. So this sort of looks at that this models the risk based on their different risk profiles and the outcomes in that are indicated in that second column of relapse or lapse, and then looking at the 30, 60, 90, 150, and 180 days after they enter the house. So this would be even if they left. So this is just looking for however long they're in the study. So what jumps out to me is that first 190 days. I mean, that first 90 days. So you can see how much it goes up in that first 3 months and then kind of levels off. So, so for that high risk profile, by 90 days, the relapse is at 24.9%, and nearly 3/4 of that 6-month risk at 34%. So once again, emphasizing how high risk that early period is. And that then for the low risk resident, the lapse is about 10 times her relapse risk. And so and for the high risk resident, the lapse of risk at 20% and relapse 34% are in the same ballpark. So that kind of suggests the high risk profile captures people who, when they use, tend to escalate, and the low risk profile captures people who slip away but don't occasionally progress. So, so next slide, please. All right, so the implications for practice, getting into that. So this one, our findings support that idea of the differentiated responses policies based on the use patterns. So we found, those different predictors. And so looking at that for lapse specifically, so there might be residents who benefit from continued housing stability. So the protective effect, the longer longer stay suggests we should be thinking about possibly moving them to another house, and if for the relapse, a higher level of care like that LA County model, and possibly for, the high risk residents for relapse, just keeping in mind possible more intensive support. So it's once again more support for employment, vocational help, and anything that can help residents. Once again, just want to emphasize these are hypothesis generating findings. Observational design of these studies. We didn't test any of this out, and this is secondary analysis, so keep that in mind. Next slide. So some supportive services that might help, as I said, the vocational assistance might help, maybe more attention or case management for those people who have that a high number of prior treatments, and then keeping in mind that sponsorship protective effects, that 56 protection reduction in relapse hazard is pretty huge. And just thinking ways, I know a lot of these programs are 12-step based, but how do we get residents involved, connected to sponsors? And then, and just keeping in mind, yeah, that secondary prevention of having that. Next slide, please. So just another part as far as the resource and equity considerations here, with that finding with the higher monthly fees. This more may reflect the resources and not the actual fees. And this might point to how if there are resource-related disparities in outcomes, it's a good thing to keep in mind. I know some houses offer different scholarships or finding out about maybe fee subsidy programs, employment assistance programs, and enhancing those support services. Also, doing some of that enhanced aftercare outreach for the shorter stay residents for people that may not stay as long. And one thing, just to go back to that pre-entry absence not coming up as significant in this analysis per se, just keeping in mind that, trying to help with more residents, trying to balance that out. Next slide, please. And then also just keeping in mind that timing. So that first 90 days are very important. That is a pretty high risk period for the relapse. And just, yeah, if it is a house, just for houses that do end up evicting, keeping in mind that effect, just as far as, trying to mitigate that. And just that, the importance of the early detection. Next slide. All right, so study limitations. So once again, as I said, the observational design can establish that causation. And then also the associations may reflect some kind of unmeasured confounding here. So there might be more going on than what we studied because, this is a secondary analysis. So there could be, a lot more of the story, which I'm sure some people have thoughts on. And then also that selection bias from missing data and that differential follow-up. So that is, the concern that the people that we are not able to follow up with have relapsed. And or other outcomes. So just keeping in mind that those are not included, and then possible overfitting. So we do, we did put a lot into these models, and that can then cause a little bit of caution as far as interpreting the results. Next slide. And then also that 6-month follow-up. So that is pretty short, so you might miss the longer term patterns. So some of the lapse group might end up being in the relapse group long term. So we don't know what happens with this at the 12, 24 months. And then also we had that self-report validity. So we used a timeline follow back. So it was self-report using calendars but no real biological testing. And then also just keeping in mind that's part of our data collection. And then the relapse definition that I talked about, the 3 or more times per week once I started using. So that might not reflect all individual experiences. So keep that in mind. Different people might define that differently. And then also no adjustments for the multiple testing because this was exploratory analysis. Next slide. But good things, adequate sample size, high follow-up rate. The competing risks revealed some stuff that would have been masked with the traditional analysis, and the findings are robust across the sensitivity analysis. Next slide. So future research, so maybe some randomized control trials to establish some causal relationships. Kind of hard to do this with one. I'm curious hear how you would think that would go, but one idea would be to randomly assign houses to differentiated response policies versus the zero tolerance, and also wanting that longer follow-up, testing those different interventions, and then looking at the different mechanisms. So, how the sponsorship prevents escalation. Does job training reduce relapse? Does actively connecting residents to sponsors help and all that? More diverse sample, and then also looking at those different outcome definitions. So next slide. So just to summarize, I know I threw a lot of numbers in some of you, but just to put this up here, so we did have those distinct profiles. So those largest effects for the relapse was the female being female, having experienced so being female was protective. Being having employment problems at baseline was a risk factor. Having a sponsor was protective, and the longer length of stay was one that was also pretty protective. We had those opposite effects for the sponsorship, and then I want to get to the discussion. So, but just know that these are just different ideas for possibly having those different response policies that need to be further tested in research and need to figure out possibly different interventions aimed at this. Okay, and next slide. Okay, so just wanted to open it up to any questions or discussion here. But also I have my email there. I know I'm not usually one to ask too many questions, so if you feel like emailing me or you have any thoughts or ideas, please feel free to email me there. But yeah, just wanted to open it
Thank
up.
you. Thank you, Liz, for that amazing presentation. So at this point, we're going to open it up for questions from audience members. And I did see that there were a few questions in the chat, but all audience members can also raise their virtual hands within Zoom or drop questions into the chat. Amy, have you been tracking some of these questions? I don't
I
see any.
have been tracking questions. So there were some clarifying questions, and thank you, Meena Subaraman, for being in the background, answering as many as you could. A lot of questions, well, not a lot, some questions around measurement and measurement constructs. John Major, do you want to unmute yourself? Do you have any remaining questions about how things were measured?
I just wanted to comment really quickly. I think this is wonderful. This is great and very important research. I've been doing some consulting lately, and in sober living homes that are managed and they have employees overseeing the operations, they are finally connecting to local detox centers and rehab centers to guide people who lapse or might have used for a few days to get them into treatment, get them detoxified, and welcome them back. That is something that's relatively new. I just wanted to point out two things. One, when it comes to self-governed sober living homes like the Oxford House model, it's different. I would argue that they're not really equipped to do that. Some might have some connections with local detox centers, but the therapeutic atmosphere of a self-governed sober living home might be a little different, and their zero tolerance policy might be justified to preserve that therapeutic atmosphere. I think this is something that needs to be discussed and eventually researched, that what you're looking at probably has to do with homes that are levels 2, 3, and 4 based on NAR level categorization. Otherwise, yeah, you can look at categorical 12-step involvement, something I was kind of hinting at. There's been some studies that are looking at doing a number of things like an all or nothing approach, and there's a randomized clinical trial over a 2-year period that had found that to be a pretty good way. And also using the PSI, the Psychiatric Severity Index, the ASI, has been dichotomized. It's a very simple formula that McClellan and others in 1983 came up with, where you basically subtract the standard deviation score from the mean, and that would be a low group, low PSI, and those who are plus 1 standard deviation from the mean are in the high group. And you basically carve out a good section of the sample, but you have a high and a low group. And there's been a number of studies saying that this is a good way as a proxy measure for psychiatric comorbidity. So I just want to throw those in really quick and not take too much time. Thank you. This is wonderful research. It's very encouraging.
Right. Well, thank you. Yeah, no, that was very helpful. Yeah, that was one of the ones with this the having the two different psych scales. The one where we had the ASI psych, and then we had the PDSQ, which is a measure of symptoms. And yeah, wanting to include them in the analysis, but not having the same one. So yeah, because it has been such a big indicator with other ones. That was one that we played around with different ways to do it. I I'll have to look. I think I did look at the one study that had more participants. I think I tried to do a sensitivity analysis where I just looked at it that way. But I will try with that because that sounds really cool. Yeah, thank you.
So some other questions that came up in the chat I think it was maybe your conclusion slide. There
Okay.
was something about zero tolerance perhaps being triggering. And I just wanted to know if you wanted to say something more about that. I think that was Stephen Clement who asked that question.
Yeah, yeah. So I apologize if some of the wording around that might be troubling. I just more meant that going back to that absence violation effect idea of that for some people that might be something that just thinking of it in those ways that once you use that it can then more trigger a relapse where it could end up being something that you're thinking that now that I use. So in that way, but yeah, not just the idea that it would cause it, but that once you do use that, the idea that being within a house like that, of being like the fear of I now lose my housing, so the fear of then reaching out for help because it's like if you reach out and admit that you would use the idea that you then might lose your housing. So just that kind of tension and how what that might mean for people and what does that answer the person's question? I hope.
Yeah, and folks, please feel free to unmute yourselves. I'm just kind of going through the list of things that were dropped into the chat. But if you have emerging questions, please feel free to jump in. Um,
So Liz, just to clarify my question is, we do have people that return to use and that they're living in the house, and our policy is immediate discharge, not exactly immediate, but they need to leave the house for the protection of the other residents. So the question is, seem to give the impression that we shouldn't be doing that if it's just a lapse, or
No. I think more. I think the pointing out that LA County model of if they are interested in and they're saying that they want to they did use you do have that obligation that you want to protect and not trigger others in the house, but possibly if you have the resources or the connections to connect them with another house if they are interested, or if there is something with them, I know sometimes there will be, more like transitional houses or even going back to treatment, depending on that. But no, I tried to, I should have been clear. It's more just saying like that, trying to differentiate between these two and how they look differently. But yes, knowing that like the message that it sends when you're trying to have this shared goal of abstinence within the house and you're trying to maintain just that delicate balance is very difficult. Yeah, but yeah.
right. So I mean, we would take them to detox, take them to another program that they feel would work for them. But unfortunately, sometimes we take them to the bus stop. That varies. Everybody's different. And you look at each case individually, specifically. So,
I kind of like to
Yeah,
piggyback really
yeah.
quick off of that. I'm involved in the case right now of the state of Washington. The state of Washington passed a law that all sober living homes cannot evict residents who lapse or relapse. They are protected under the landlord-tenant law. And at best, you have to give them at least 3 days before you petition a judge for an emergency eviction.
Ours is
I do not believe in that. I think that was
yeah,
ill-founded, but
we're not a landlord. It's
I
a
know.
resident agreement that they agree to being removed from the house if they break the rules of the house.
I
Uh,
completely agree with you, Stephen. I'm just saying that
right,
there's some people who have come up with these grand ideas that really defy what the research is saying. And I'm just really congratulating this kind of research because it shows, no pun intended, a very sober approach about how to deal. Because I believe, and I think most people in here, some people slip, and we have to be careful using that term not to justify a relapse. And I think that we need to come up with some data to justify an intervention necessary to keep people in and to not be ashamed of having to slip versus those who are secretly using and they're not really engaging in a recovery. They're just merely complying because of various reasons.
right.
But I just want people in here to know about this law that recently occurred in the state of Washington. It's bizarre.
Yeah.
Oh,
So Gil Ramirez had a question that was just dropped into the chat. Were any of the sober living programs identified by the study clearly categorized under the tier level ladder identified by SAMHSA, or did the study focus on one of the level types, the sober living house?
Yes,
So Liz is nodding her head. Yes, it is
yes,
just
tier
sober
two.
living
Yeah,
houses.
just sober living houses. Yeah, and so that's I think we had talked when using recovery housing and kind of thinking like, okay, how I think the commenter who had said something about how this would be look different in Oxford houses, but yes, this was all in sober living houses with the house manager that um, would be the one kind of that would be looking at this. But yeah, that's the type of house that is this. And Lynn, you had a question?
oh, well, thank you so much, Liz. This is a really very much needed research, and I'm really so impressed by what LA County is doing. It's really such a really, I think it's a vital source of resource for people struggling with addiction. So I'm just wondering, for um, people who are either due to mental health disorder or maybe physical health issues. So if they do receive prescriptions, and the prescription sometimes, for people suffering pain, they probably might really have oxycodone. So in that case, if a resident is in that situation, so is that kind of a suggested not really considering sober living? So might consider some alternatives. And so I'm just really kind of wondering for this type of, people, just they because they have the health needs, but their prescription happen to be actually, might really trigger the concern of other residences, because the people living in those sober living residences, they do have struggles. So you want to hear your thoughts.
Yeah, I know Amy might and other might be able to handle better, but just with houses, I know the housing policies it differs from house to house as far as whether or not they would be comfortable with having residents like that and whether or not they have the staff that can accommodate that. Just because, yeah, handling the medications and everything, it tends to be more of a house by house basis. But yeah, I think that before it had been a lot of houses had not wanted to take that on because of the other residents that could be put at risk. But I think there is a little bit of a movement to try and have houses that allow that. But I don't know if anyone else wants to comment any more on
I
that.
think that your answer is great, Liz, and we're getting close to the top of the hour. The
Okay.
only thing that we didn't really address, and maybe it's something that we can all think about, is kind of a question that John brought up really early on, is kind of what is the difference in the atmosphere in a house that has more of a relapse kind of abstinence-based policy versus a house that would be willing to work through relapse. And so that's, something, again, we probably can't address it now in the last 5 minutes of the webinar, but something for us to think about, and for you, and kind of as you're cogitating the interpretation of your findings, to think about as well.
Yeah.
So Carmen, I think we need to pass it back to you.
Yeah. Well, thank you all for that wonderful discussion. Really appreciate it. Now, before we leave you today, I want to give you a heads up about some things that are coming up in the next couple of months. Next slide, please. So next month, we're going to be featuring Dr. Cindy Nichols, and the title of her presentation is Examining Implementation of MOUD and Recovery Housing Through the Lens of the Consolidated Framework for Implementation Research. And in May, we'll hear from Dr. Jennifer Miles, and she'll be presenting patterns of utilization of medications for opioid use disorder among Philadelphia recovery home residents. So unless otherwise advertised, the I-STARR webinars are held on the third Tuesday of the month from 11 to 12 for those on the West Coast, which is 2 to 3 for those on the East Coast. And you can register for any or all of the webinars that we have scheduled on the I-STARR website. And you can also stay connected with the I-STARR project through our social media accounts, which are listed on this slide. Next slide, please. And now, while we're on the I-STARR website, we'll also provide information about the I-STARR training series. And that is 12 separate webinars on training topics for recovery housing operators, as well as those interested in conducting research on recovery residences. And those who participate in all 12 webinars in the training series receive a certificate of completion and could be provided with the option of being identified on the I-STARR website as someone who's completed the training series. At this point, because the live series has ended, we only can track completion of the webinars if you register for the series and view the webinars on the I-STARR Learning Management System on the website. So if you have any questions about the training series or about how to complete it, please reach out to us. So the next topic is this National Conference on Addiction Recovery Science. We want to let everybody know that the call for proposals is now open and that the submission deadline is May 6, 2026. So this is a virtual conference on recovery science. So we encourage anyone who's interested in attending to please look into this conference, or if you're interested in submitting a proposal. Next slide, please. So we're running out of time, and I just wanted to thank our presenter, Liz Mahoney, for an amazing webinar, and everyone who's been in attendance for their time and attention. And we hope to see everyone back here again on Tuesday, April 21st, and enjoy the rest of the day and the intervening month. And thank you so much for being here.
Thank you.
Thank you.